Welcome to SBB University Caregiving Resources. I'm Kathleen Warshawski. Today we're going to talk about ethical considerations for self-determination in long-term care during COVID-19. We'll touch on some important topics, such as areas of ethical considerations for self-determination, risk of dignity, and safety in long-term care during COVID-19. We're going to identify some ways to advocate for the rights of older adults. We've got a great lineup of panelists for us today. First, we have Benjamin Surmi, social gerontologist from Kelch Communities, Susanna Solfsteed, ombudsman with the Senior Source, Mindy Kitchens, ombudsman with the Senior Source. And with that, I'm going to ask our social gerontologist, Benjamin from Kelch Communities, to go ahead and take over and moderate today's program.
Thank you, Kathleen. Yes, it's a timely topic. And I know you received quite a few questions already from folks who are attending today. And so I look forward to hearing more what our experts will be saying about those questions. I'd love to just start off maybe with you, Susanna, and just tell us a little bit about what brought you into this work of being an ombudsman, specifically with seniors. Like, what you could have done anything. You could have advocated for children and all kinds of other populations. Why'd you pick seniors, and why do you do what you do?
Yeah, well, thank you so much. And thank you for this opportunity to be with y'all today. So, I've always had a special place in my heart for older adults. My parents were older themselves when I was born. And then I had a next door neighbor who was in his 70s when I was growing up. And he just really influenced, I feel like, my career path. I've got my master's in social work. And when I was in school and was doing my internship through that program, I got placed at an area nursing home. And I ended up going on to work for that facility for about 3.5 years and just fell in love with it, and then moved from there over to the Senior Source. So working with older adults has really been my passion just throughout my whole life. And I can't imagine not doing what I do.
Well, we're glad you're in our field. This is very good. Mindy, how about you? Tell us a little bit about what you do currently, where you are, as well as how you also got into the field.
Of course, and thank you for having me. I'm an assisted living ombudsman, and so I visit assisted living facilities exclusively and advocate for residents' rights. My story is a little similar to Susanna's. I am also a licensed social worker. I grew up helping my mom take care of my great aunt, who is still alive with us. And that experience really gave me a heart for working for older adults. And so I'm in my role now just because I love the advocacy. Working in a facility is not exactly the right fit for me, but I really enjoy being able to advocate for the residents that I serve.
That's awesome. We need lots of advocates. Hey, so I think, if I remember correctly, you have a little bit of a PowerPoint to give us a clarification between maybe what an ombudsman is versus what the adult protective services is, et cetera. Could you maybe break that down for everybody, just so we're all on the same page of where you two come from on the spectrum?
Yeah, absolutely. So if you'll go back to, I think it's the first slide after the title slide, it gives just a little bit of an overview of the long-term care ombudsman program. Yeah, that's it. So we are both a state and federally mandated program. We're mandated to advocate on behalf of residents who live in nursing homes and assisted living facilities. Ombudsmen work on behalf of the residents to resolve problems, ensure their rights are protected. We advocate for the residents' quality of life and care by making regular, unannounced visits to the facilities where we go room to room, talking with the residents about their care and working to resolve complaints on their behalf. Ombudsmen are independent, meaning we don't work for the facility or anyone other than the resident, and our services are confidential and free of charge. Ombudsmen are also a resource for people in the community going through that overwhelming process of selecting a facility for a loved one. And while we can't recommend facilities, we can help narrow the list of options based on an individual's needs and provide information about those facilities. Locally, the program that Mindy and I work for is housed at the Senior Source, and we are responsible for serving more than 16,000 residents in the 81 nursing homes and 231 assisted living facilities in Dallas County. And then there are other ombudsman programs that serve the surrounding counties. And I think on the next slide, we've provided contact information in case any of the participants need to know how to contact an ombudsman in one of those other counties. And then if you'll forward 2 more slides, we've got a description of the differences between, oh, nope, it's not that one, sorry. We do have a slide where it gives a description of the differences between the long-term care ombudsman program, the Texas Health and Human Services Commission, which is our long-term care regulatory agency here in Texas, and then Adult Protective Services, because we all do serve a different role in terms of protecting older adults. I've given an overview of what the Ombudsman program does. Long-term care regulation, which is housed again in the Health and Human Services Commission. They are the state regulatory agency responsible for providing oversight and regulation of both nursing homes and assisted living facilities. And so they are going to be the entity that will investigate complaints and then cite facilities for any deficiencies, and they have the ability to enforce the rules. And then Adult Protective Services, or APS, they work to prevent abuse, neglect, and exploitation among older adults, primarily out in the community. So those individuals who are not living in a long-term care facility. Typically, APS is not going to get involved with situations involving abuse, neglect with long-term care residents unless the perpetrator is somebody who's from outside of the facilities. So that just gives you a little bit of an overview of the differences of the 3.
Beautiful. Was there anything else on the slides you wanted to cover while we got them up?
Yeah, I mean, I think we do have some additional information, just talking about how to advocate on behalf of individuals living in facilities. And we wanted to share some different resources. I think if you'll go to one slide before that, you know, there's a lot of different steps that we can take when somebody has a concern. And we always encourage residents and the families to work with the facility, if at all possible, taking a concern to the administrator or whoever is in charge at that building and bringing it to their attention. A lot of times that's all it takes, and they're able to work through the issue and get it addressed. But sometimes it may need to be worked up the chain of command. And so if you take it to whoever's in charge at the facility and you're not seeing the response that you're hoping for, then the next step that would be appropriate would be to reach out to the corporate owner if they are corporately owned, or whoever is higher up above that administrator. Certainly, we want people to always know they have a right to contact the ombudsman. Again, we're there to be an advocate for the residents. We aren't going to necessarily step in and address a complaint unless the resident and family want us to, and we have to have resident consent before we take any action. And so sometimes our involvement may just be talking through the concern and providing guidance to the resident and family on steps that they can take. I mean, we really work to empower them so that they have the tools they need to speak up for themselves. But we do know too that unfortunately there's a real fear of retaliation. Residents are afraid that if they complain, the staff will do something to get back at them or stop providing care. And I think, you know, that fear of retaliation is certainly heightened right now during COVID-19 when families don't have the easy access to residents that they had prior to this pandemic. And so, you know, sometimes residents don't feel comfortable speaking up and they may want the ombudsman to intervene on their behalf. And certainly we're available to do that as needed. Next, always have a right to file a formal complaint, again, with the Texas Health and Human Services Commission. And we've provided information on this slide about how to do that. And then another step that individuals can take is to reach out to their lawmakers, contact your state representative or state senator about the concern that you're seeing. That can generate a legislative inquiry and get more attention on the problem. And we certainly have seen situations where that has brought about resolution. You know, it's not something we encourage people to do with every complaint, but there are certain situations where that might be appropriate.
That's very helpful. That is very helpful. It's great to see it all broken down clearly, step by step, because sometimes you walk into a situation and you're just overwhelmed by the problem itself. And then how do you go about fixing it? So what an awesome resource to be able to have someone come to someone like yourself and get some guidance on the next steps. Now, I think let's start with this in our conversation. Our discussion is called Dignity, Risk, Self-Determination, and Safety, Ethics During COVID-19. And I think where I'd like to start is just a snapshot of where we're at today in the counties that are represented on this call, as far as you know them. I know it's changing every day. So basically after this event, things might not be the same, right? And so take everybody who's listening, take that with a grain of salt, right? They're going to share some things about what they know today, but it may not be the same tomorrow. So tell me, what are the current policies in Texas and local counties regarding things like families visiting an aging relative for a social visit in a nursing home, assisted living, memory care, or hospital, families visiting aging relatives to check on their health and wellness? Let's start with those two. I just want to visit for a social visit. I need to check to see how they're doing. Are they being taken care of well? Those two different types of visits. Are they allowed? What's going on with that?
Okay. Yeah, I mean, this is certainly a very timely question. And as you mentioned, it is changing. It's changing quite a bit. And so, like you said, we'll talk about where things are today, knowing that tomorrow it may have changed some more. So just to start, skilled nursing facilities or nursing homes are regulated at both the federal and state level, while assisted living facilities are only going to be regulated at the state level. And then both could be impacted by local county orders as well. And that certainly is the case here in Dallas County. So we just had an update at the federal level. Last week, the Centers for Medicare and Medicaid Services, or CMS, they are the federal agency that provides oversight for our nursing homes. They issued an updated memo with revised guidance related to nursing home visitation. And that guidance was developed as a result of progress towards vaccination of our residents and the facility staff, and then also just in recognition of that physical and emotional toll that the separation from family has had on residents. Specifically, the new guidance is stating that facilities should allow indoor visitation at all times and for all residents, regardless of vaccination status, except for a few certain situations. So, if the county positivity rate is over 10% and fewer than 70% of residents in the facility are fully vaccinated, that would trigger them to restrict those indoor visits. Or if a resident obviously has a confirmed positive diagnosis of COVID, or if they're in quarantine, then that would be another situation. But we're excited to see this coming out from CMS because it is moving us in the right direction in terms of opening these facilities back up. With that being said, though, here in Texas, facilities fall under the jurisdiction of the Health and Human Services Commission, and they issue emergency rules related to visitation, and they have not updated those rules yet. I mean, we are anxiously awaiting and hoping to see an update to those emergency rules, but right now we are still operating under the expanded visitation rule that was released back in September. And so that governs our nursing facilities. That is also applicable to our assisted living facilities as well. And so it does allow for certain types of visitation to occur. I think the big one is for the essential caregiver visits, where residents can designate up to 2 individuals to serve as their essential caregivers, to come in and visit with them. Those visits do still have to be scheduled at this point in time. Essential caregivers, depending on the facility's policy, they have to be tested on a regular basis for COVID and obviously have a negative test. And there's just certain criteria that they have to meet to be able to do those visits. The visitation rule also did allow for some other types of visits, including indoor plexiglass visits, outdoor visits, open window visits, and these are for individuals who are COVID negative. And then of course they allow closed window visitation for all residents, as well as end of life visits for all residents. And so that's where we stand right now in terms of the emergency visitation rule here in Texas. Again, we're hoping that we will see that be revised to accommodate these new recommendations from CMS, but that as of today has not happened yet.
How about aging relatives leaving where they live to visit family members at their homes? What does that look like?
Yeah, absolutely. So, you know, residents still have a right to leave the facility. That right has never stopped. It was a little bit more difficult to advocate for back at the very beginning of the pandemic, but HHSC guidance very clearly specifies that if a resident is not gone overnight, if they practice social distancing, they follow all infection control measures, and they're not around somebody who is COVID positive or suspected of having COVID, then the resident should not be required to quarantine upon return to the facility. You can expect that facilities are still going to screen the residents when they come back. And if the resident or their family is not able to answer the questions or provide the needed information, then the facility could require residents to quarantine at that point. And then those same requirements apply for residents who maybe are leaving for a medical appointment, or such as like a dialysis appointment or some other type of doctor's appointment. Now, with that being said, we certainly have received complaints regarding facilities who aren't following that guidance and who are trying to require residents to quarantine regardless of how long they've been gone. And so that's something that we've had to step in and address as needed. So.
And just to clarify, I know in nursing homes, it can be challenging with staying overnight somewhere, but in assisted living, obviously residents have the right to leave and stay overnight as long as they want in someone's house. How does that impact this rule in assisted living?
I'll let Mindy take that one.
Yeah, residents can always leave and stay overnight at any time. Like Susanna said, it was difficult to advocate for that early on. But if they choose to leave and stay overnight somewhere now, they will be required to quarantine upon return.
Okay. What about seniors participating in on-site social activities with their peers? Let's say a group who's having a book club. How are things standing right now with that?
So both at CMS and the state allow those social group activities as well as communal dining, you know, as long as residents are COVID negative, and that includes those who have fully recovered and they meet the CDC criteria for discontinuation of the transmission-based precautions. Group activities are allowed. They are required to limit the number of people to allow for at least 6 feet of social distancing, practice hand hygiene, have to wear their face masks. They can't use shared items. And then of course they have to clean and sanitize the area before and after each activity. But yes, they are allowed to do that. We are hearing concerns, though, from some facilities that are not allowing that to happen. We actually got a call just earlier this week from a family member whose loved one is, he's lived in this facility for about 5 years, and he's very active, very alert and oriented, and he basically has been confined to his room for the past year. The family are designated as essential caregivers, and so they are able to visit with him, but they've tried to visit with him like by taking him outdoors just to visit outside of the facility, and the facility's not allowed that. They've not had any group activities. The residents are still eating in their room. And so we are, you know, we're going to be working to address that, not only for that one resident, but really for everybody in that building, just educating the facility so that they understand what is allowed, because that's extreme. I mean, a year has passed now, and just the impact, not only physically, but emotionally, that this isolation has had on these residents is just devastating. And so certainly we're going to be working to get that addressed on their behalf.
And then I think you've already answered this one, but families visiting aging relatives during the last days of life, sounds like that is fully okay.
It is. I mean, that's something that's been allowed back to the start of COVID in terms of allowing those end-of-life resident visits for residents who are actively dying, regardless of their COVID status. It's allowed in all facilities, both nursing homes and assisted livings, and whether or not they've got COVID in the building. You know, the concern we've heard is how is actively dying defined? And sadly, we've heard of situations where family haven't been able to get there in time to be with their loved ones.
Mm-hmm. Okay, so that brings me to my first question regarding advocacy, right? Because one of the things that we're kind of dealing with two sides of the spectrum today, right? On one side, we're going to deal with some of the rules and how they relate to ethics, right? Mm-hmm. But the other side, we're going to talk about like some rules that are opening up opportunity for people to exercise their rights, and yet facilities and communities not following the basic rules, right? So what I'm curious, let's start there. If a healthcare organization or senior living organization has developed policies that are more strict than the state or county policies, what can a family do to advocate? And I think you touched on this earlier with kind of your series, but give me an example of maybe someone you've worked with who was in this situation where they were not allowed to go outside, which has never been in the rules ever from the beginning, or they were not allowed to have that essential caregiver because the community just didn't want to mess with the program, right? How did you help someone in a situation like this?
Sure. Yeah. I mean, we definitely encourage people to reach out to the ombudsman program to discuss a specific situation and learn, about the rules to determine whether it's something that is allowable and within the bounds of the guidelines. For the most part, facilities should not be implementing policies that are stricter than what the state or county requires, but there could be some exceptions. And like you mentioned, with the essential caregiver visits, I think that's a perfect example. The rule stipulates that facilities require a negative COVID test no more than 14 days prior to the essential caregiver's first visit. But it also requires that facilities develop a testing strategy, and it leaves that up to them in terms of what that looks like. And so we have some facilities that have the strategy of only requiring that first test, while others have a much more stringent policy, and they're requiring testing every 14 days or even every 7 days. And so that is allowable under the emergency rule. It's stricter than what that initial testing requirement is, but it is something that's allowable. But certainly we want to make sure that that testing frequency isn't prohibitive or prevent the family from being able to visit. And so, we've had multiple situations where that has been the case, and we've educated the facilities on what the requirements are. When needed, we might reach out to long-term care regulation, again, that state regulatory agency, and get them involved if we need to. Just really also just trying to appeal to the facility, just again, why these visits are so important, and just the impact it's had on them, just why it's so important emotionally for the residents. And, I think we've had some good success with being able to get the facility to kind of back down on some of those requirements. It really just depends on each individual situation. Mindy, if you've got other examples that you want to share, please jump in.
Yeah, I mean, I've had this come up more than once where there's been a situation where an essential caregiver can't get in due to some of the testing policies. And I mean, it comes up so frequently that I kind of have a standard course of action for how to advocate at this point. And it's not always the ombudsman jumping in and making waves at the facility. One of the things that I try to do in these situations is help the family to understand exactly what the rules are, and then I help them to advocate for themselves and learn how to ask the right questions to get in. And sometimes that's enough. Usually the family can resolve it before I even need to step in, and then they'll let me know, hey, I was able to see my mom, and that's a great feeling. So
Any other success stories you can tell us, generalizing, changing genders or whatever, regarding anything that came up during this past year where someone wanted something that was in the rules? I mean, they weren't asking for anything outside of what the state and county said, but their particular community facility was not having it.
Yeah, I had a facility that was not allowing any essential caregiver visits at all. They were still pretty afraid of residents coming down with the virus. They didn't have any cases. And so that was a situation where I did get involved with the permission of the resident. First, the family did make an attempt to request what they wanted with my help and some coaching through some emails and phone calls. But ultimately, I was able to reach out to the director of that particular facility and have a conversation about the rules. I also tend to lift language from the emergency rules and share it with directors, and that usually helps put things in perspective. And so just helping that director to really change the perspective, understand the rule, we were successful in getting the families in. And that's been more than one case for me.
Yeah. Yeah. I have a similar story, as a gerontologist, I have all my family and friends are always calling me with their questions, right? And so I had some family and friends down in SoCal, Southern California, and a good friend of mine that had multiple sclerosis, was getting very old, and he was in a nursing home at this point, and the nursing home would not permit any visits from basically anybody other than FaceTime visits, right, on an iPad. And I was just so frustrated hearing these stories. And so I went online, and in 10 minutes, I had the rules, and I copied them and sent them to the essential caregiver, basically, of this friend of mine. And just having the rules in front of them empowered them, and they were able to go and advocate, and they were able to get 3 visits a week until he died, right? And so it was wonderful to be able to take that little step. And it makes me wonder sometimes how much of what we're dealing with right now, where folks are not following basic rules, actually has to do with there's so many different rules changing all the time, and facility administrators are trying to just keep the ship float, right? Keep the ship floating, and they don't have time or the legal expertise to necessarily read through the rules and go, okay, I think I'll be safe doing this. Is that what you're finding too? Is part of it's not really like I'm a bad human and want to control people's lives. I just don't really know the rules.
Absolutely. I mean, the rules are changing, and it's hard to stay up with all of the changes. And when you look at what these facilities are going through, just trying to protect their residents and keep them safe. And if they've gotten COVID in the building, and we've had facilities where they've had a significant number of staff who've been positive at the same time, and so unable to work. And so they're dealing with staffing issues. And so there's so much that's going on there in the facilities that they're dealing with there in the moment. And again, trying to keep their residents safe, that it can become difficult for them to keep up with all of the changes that are going on. And, I think our state regulatory agency is doing a great job of putting information out there. They offer weekly webinars, both for nursing facility providers and a separate one for assisted living providers. And as ombudsman, we participate in those weekly, but it's a lot. I mean, that's a time commitment to keep up with that. And so we really have made that a priority ourselves to try to stay on top of that, so that we can then get that information pushed out to our facilities that we feel like is especially critical for them to have. Because yeah, we're definitely finding that they don't have the time to log in to these webinars, and there's emails coming out from HHSC, but again, it's hard to find the time to read those emails. And so just, if we're able to get the information and condense it and get it to them, we feel like that hopefully is helping them get the most critical information while still being able to focus on providing that care for their residents.
I like that. Let's take another look now on the other side of the spectrum, right? And so let's think about ethics for a moment, which is different than what's legal, right? As we all know, most of us on this call know, you can have laws that are unethical, right? I mean, we can go through our history books and point out laws that were unethical throughout America's history, right? We can even look in the Constitution and find things that were unethical at certain points that are not in there perhaps anymore. And so ethics and law are two totally different realms, right? Law is practical. It's what a particular community, a particular society decides is okay, whether or not it's actually ethical or not, but it's the law. And then there's what's ethical, which is kind of based on a higher level of principles, morals, agreed upon or received understanding of what is good for our society, right? So, before COVID-19, America had worked really hard with a lot of advocates over about 100 years, moving towards an ethic of self-determination. an ethic in which if you live as someone with disabilities, you have the right to make decisions for yourself, right? If you live in some sort of communal setting, you have a right to make decisions for yourself. Just because you move into an institution, you don't lose your civil rights, you don't lose your rights to decide what kind of healthcare you want, what you want to wear, etc. Right? We've worked really hard, right? We've in just in the past 40 years, we've seen people do incredible work. I mean, when I was born, people were still being tied up in nursing homes to chairs. Like when I was born, that was okay. And that was actually the preferred method by regulators in the United States. One of my good friends, Joanne Rader, who started in Oregon as a nurse in nursing homes, she was one of the first people to be a part of removing restraints. And the regulators at that time were very frustrated by her doing so. And were very against her removing restraints because they prevented falls. And it took a long time and many, many people advocating to remove restraints. That's just one example of how far we've come in just, I'm 40. So 40 years, we've come huge far. Right? It's like we can't even, like Mindy and I can't even, and Susanna, we can't imagine. The three of us can't imagine life where it was okay and actually required to tie people up. We can't imagine that. And so we understand that the law and ethics are two totally different things. So what I want to ask is, we worked hard to get to this point where self-determination is really important. But then, so here's how I want to ask the first question is, what are the ethical reasons for embedding this principle in our healthcare practice? And let me set the context with a few examples, and I'd like to hear from you why you think self-determination, if you do think self-determination, is an important part of the ethics of healthcare in America. So the first example is a person with dementia, not being forced to take medications, eat, or take a shower. That's a fairly established principle that we cannot force someone to do those things. They have the right to refuse. A person who will die without chemotherapy chooses not to receive the treatment because they want to attend their daughter's wedding feeling well and not feeling disgusting because of chemotherapy. That's self-determination. A person living in assisted living with diabetes who cannot be forced to only eat diabetic ice cream, but can choose to say, I want the real deal, right? A person who is dying may choose to stop eating and to not permit mechanical feeding. They can say, no, I know you want to do this for me, and that's the safest thing for me, but I prefer to pass away without that. And then a person understands that skiing may not be good for their heart condition. However, it means so much to them, they choose to continue skiing. So these are examples of self-determination. Give me your perspective as social workers on why this is or isn't a continuing important principle in the ethics of healthcare.
Yeah, absolutely. So as a social worker and then as an ombudsman, I'm obviously a huge proponent of self-determination. I mean, that's a foundation of the work that we do. I think some rights, and talking specifically about long-term care residents, but some rights are clear-cut. So right to be treated with dignity and respect, the right to receive good care. The right to self-determination is one that is in the regulations, both nursing homes and assisted living facilities. Other rights, and somewhat including that right to self-determination, though, I think have more controversy around them and have more ethical dilemmas around them because people have underlying values and misconceptions about them, right? So right to consume alcohol, right to engage in sexual relationships, right to refuse treatment. Right now, even the right to leave the facility during COVID. I mean, there certainly have been some ethical controversy around that with some people. Like you said, the ability to take risks is a basic right that we all have as citizens of this country, and that does not go away when somebody becomes an older adult and when they move into a long-term care facility. They retain all of the same rights that we have. And I think as professionals, we need to view the resident or any other older adult as an adult whole person who gets to make decisions, good or bad, just like the rest of us. I mean, we all take risks. We all make bad decisions pretty much every day. I know I certainly do. So, I think too often facilities view the individual as a patient rather than a resident. They have more of that medical model approach, and that certainly plays in to trying to restrict some of that self-determination. And I think we need to remember person over patient, and to help us be able to do that, we have to really take time to think about our own beliefs and opinions and values. We know as social workers, we shouldn't be imposing our own values on our clients, and that's certainly true for us as ombudsman, but we have to know what those values are first before we can even set them aside and just ensure that they don't interfere with the client exercising his or her choice.
Mindy, how about you?
Sorry about that. I agree. I'm also a huge proponent of self-determination. I think right now we have, a different set of issues. We still have some of the same issues that we had with self-determination, like Susanna mentioned, sexual relationships between residents, drinking alcohol. Some of those issues are kind of exacerbated due to the pandemic, but then you also have issues of like residents trying to leave, residents trying to have visitors, residents not wanting to wear masks. And so I think it's really important to try to respect the residents' right to self-determination and also keep as many people as safe as possible. We have a couple of examples of situations where residents, needed the right to self-determination. A couple of controversial ones. There was a resident who was alert and oriented and had chosen not to eat. And that is, it's a liability for the facility. They want that resident to eat. They want the resident to be safe. And so there was talk of issuing a discharge for that resident because the facility felt they couldn't meet the resident's needs. Well, the ombudsman on that case worked with the administrator, the director of nursing, the social worker, and validated their concerns. Of course, they are right to be concerned about the residents' safety and health, but also reminded them of the residents' right to self-determination. And so if the facility has done everything that they know to do, and if they have documented all of the things that they have done and what exactly is going on, they really need to let the resident make the choice to eat or not eat. And it's that resident's right to refuse care. It's not that the facility can't provide the care, it's that the resident doesn't choose to accept the care. And so that's I think an extreme example of the right to self-determination and an ethical gray area for the facility. But I think the take home is you have to let them exercise that right, and you can't discharge them for exercising that right.
It's a really helpful example. Any other examples that have come to mind related to this issue of self-determination?
Sure. I mean, we've had residents who maybe have been on an opioid. They've had pain issues, perhaps for a long time, and they get labeled as having an addiction and get treated badly by staff, maybe even labeled as drug seeking. Honestly, we don't know what a person's pain level is. And that's really a negative statement to label someone that way. And then you're subjecting the resident to live with the pain because you personally don't think it's right for them to get that medication. And so we have had situations where we've had to advocate for that resident to continue receiving that medication. And I acknowledge that there is a huge crisis related to opioid use in our country, but I think sometimes in our facilities, we're too quick to jump to that conclusion about those residents, and that they have that right, and sometimes they have that need, and that may be what they need to help them live the best life that they can based on their situation. I think something else that comes to mind just with this discussion is with self-determination. I think as professionals, we do have a duty with our residents or clients to have the difficult conversations with them to ensure that they understand the potential risks that they're taking by the different choices that they're making or the behaviors that they're choosing to engage in, so that they can make an informed decision. And by doing so, that helps us be able to support that right to self-determination. And so weighing the benefits and risks and everything, that's important for the facility to have that conversation, or any of us as professionals working with older adult clients to help support them in that right to self-determination, having those difficult conversations with them.
Any others from your knowledge?
I'm sorry, repeat.
Or just any other examples of this, really caring about the principle of self-determination? Any other examples?
Yeah. I've got another.
Go ahead.
I'm not sure what that echo is. I have residents who have regularly left the facility forever, high functioning residents who maybe they go out and visit their friends, maybe they're purchasing, snacks or other items. But I have some residents who purchase beer on a regular basis, and that's one of those tough ones where professionals might have some opinions about older adults, people in long-term care who drink alcohol. And so early in the pandemic, that issue came to a head because this facility went as far as changing the codes on the doors so that the residents couldn't leave to purchase their beer. And then they also were unwilling to purchase the beer for the residents due to some personal beliefs. And so you have a situation where they're trying their best, in a time of heightened emotion in the pandemic, to keep everybody in the building safe. You don't want people to go in and out and bring back the virus. But they're literally locking the residents in and denying them their right to drink alcohol. And so that was, again, a situation where I educated on the rules and advocated for those residents' rights to drink their beverages and get out of the facility. And it worked out, but that's just one of those tricky ones, where there are so many, moving pieces and so many different people that the facility is trying to keep safe, and personal values that they don't realize are impacting their work. And so it's kind of a tough needle to thread to really get them to look at their bias, and also get the resident what they want while keeping the other residents safe. Never an easy answer.
It's so helpful to hear real examples because they give us an idea of what's really going on, right? Some of us work in settings where we practice this so much, it's hard to imagine that in 2021, we're still dealing with some of the things you're talking about, right? You're making it real to some of us who think that we read all the great books about person-centered care. And so we think, yay, we're just awesome here, right? And then you hear stories like this and you go, oh my gosh, this is 2021 and we're still dealing with some of these issues. Now, less common in US healthcare and legal systems, less common than this principle of self-determination, is a principle that's growing internationally in momentum, and it's the ethical principle of risk as dignity. In other words, it's one thing for someone to choose between fairly safe options or fairly acceptable options socially, and it's another thing for someone to take a risk that many people in society would say, oh, I would never take that risk, right? And so they're a little bit different. They're kind of the same. This is a self-determination idea, but it goes a step further, right? Because someone is taking a risk that many people consider socially unacceptable or wouldn't do for themselves. So a few examples. Two people with dementia want to have sex with one another. Second example, a person wants to walk even though being seated is much safer and they prefer walking. Number three, a person wants to live at home even though they might wander away in the middle of the night, right? Someone wants to go skydiving when it might actually kill them, right? But that a fundamental part of humanity is the ability to decide, you know what? this risk matters so much to me, I'm going to take it. And much of civilization is built, obviously, by people who took those risks, who didn't stay in a little house, but went out and fought a battle or did something, wrote a play that everybody was like, how are you going to make that happen? So I'm curious, this isn't practiced widely in America. We're still very safety conscious in our legal system, and it can go back to bite someone who is a kind of caregiver for someone who wants to take that risk. They take that risk, something bad happens, it can go back on the person who is responsible for caring for them. If that principle became widely accepted in the United States, how might that change or influence the work of ombudsman, do you think? Just imagine, 10 years from now, if risk equals dignity, people are allowed to make risks. How might that impact your work? Let's start with you, Mindy.
Sure. So as ombudsman, we really largely follow that principle in our work every day. We're resident directed, so we will educate to the extent that we can, but no matter how much education you might provide, sometimes you're not going to change somebody's mind. They are going to choose to engage in whatever that risk is. And I know that myself and everybody on this call today has taken some kind of serious risk in somebody else's eyes more than once. And so our residents and older adults are no exception there. In cases where a resident might have dementia, we try to understand what their wishes might have been prior to the onset of dementia. And, I think one of the ways I like to look at this is from one of the addiction treatment models, but it applies here. And what I'm talking about is the harm reduction model. And that's really recognizing that people are going to engage in risky and potentially dangerous activities. They just are. There's no way around it. And so I think it's our job as professionals to educate, obviously, on the risks, but also to find ways to make that activity less harmful. What can we do to keep the person safe while they engage in whatever this risk is, and minimize it? And so we want to explain the consequences that might not be very effective, but some examples of harm reduction in these kinds of instances, they go back to the examples you provided. Residents who are having a sexual relationship, well, you want to protect their right to have that sexual relationship. And so what can you do to make it safer? Well, you can provide condoms, you can provide STD testing, any kind of contraceptives. There are ways to make it safer for residents to engage in risks. You really have to think outside of the box, and you really need to understand your personal biases to do that effectively, but it is possible.
And Susanna, and specifically, I'm going to twist it a little bit for you.
Okay.
Imagine 10 years from now, the legal system has caught up to you two, right? Like you two are here. The legal system's still like, oh, we're going to sue the pants off you if anything happens, right? So imagine the legal system has caught up with you. Now, how might that change the ombudsman work?
I think it'll make our job easier. I think it opens it up so much. And, I envision in that type of situation, professionals becoming more creative and collaborative and working with others to find solutions to help our residents and our clients just live out their lives in the most meaningful way possible to them. And obviously you're right. There need to be some legal changes, and the legal world needs to catch up with us, and also, regulations for facilities as well. I think there need to be some changes with that. But, I think in that world, if we got to that point, I think it does make our job easier, and that right now we do advocate a lot for self-determination and residents to make those choices. And if we live in a world where that is embraced and that right to take risk is embraced, I just think it opens up so many new things for residents to just have a meaningful life.
Now, so you've got it looks like we have 95 folks here today, and most of us, I assume, are some sort of professional in a senior living healthcare setting. And so, what we've been talking about today is both learning the real situation practically of what the legal standards are in our communities for visits and for leaving the community, having some basic fundamental human rights restored to people who've kind of had them stripped away during this pandemic. And then we've talked about these larger principles. We haven't applied them to the whole COVID pandemic because it can get very challenging to apply them, but that's why we're talking about them. Self-determination and someone's ability to maybe say, I'm going to visit with someone because that's what I want to do. I know it might be risky and may kill me, but that's what I want to do, right? So we're talking about the self-determination, dignity of risk. So our folks on this call are probably wrestling right now with, what's my role? Like, I want to be an advocate, both for the safety of everybody and for self-determination. What's my role, especially if I'm seeing things around me that I don't think are right? What would you say to the nurses, the directors of community relations, the executive directors, the activity directors, the different liaisons on this call? What would you say to them? What's their role? How can they be effective? Mindy, why don't we start with you?
COVID-19 definitely added a new layer of complexity to the discussion and conversation about self-determination. But even in the middle of this pandemic, we all still have the responsibility to find a way to help support our clients and our residents with exercising that self-determination to the extent possible. Keeping in mind that right now there are some different things that we need to keep in consideration related to how choices may impact other residents, right? But I think definitely knowing that you aren't functioning alone, you're not operating in a silo, there are other professionals out there. And so take advantage of that, reach out to other professionals, find a way to connect and talk through the specific situation and get support from other professionals. I mean, as ombudsman, we certainly support residents' right to self-determination. We're advocating for that on a daily basis, but that doesn't mean we don't struggle. Even, ethically, we struggle daily too, and we have to keep our personal beliefs in check and everything. And so we're consulting with each other all the time, and I certainly encourage other professionals to do that as well, whether it's reaching out to us to talk through a situation, but I mean, there's just a huge wealth of knowledge and experience in the Dallas area with professionals. And so definitely finding a way to connect with others.
Mindy, what would you say to these professionals on the call today? How can they effectively support seniors right now in living the life of their choice?
Well, I think, first and foremost, I think the thing to know is that it's okay to not know the right answer. It's okay. You are never going to have the right answer in every situation. And so, like Susanna said, you can always reach out to the ombudsman to talk something through. I think there's a little bit of a misconception that we are, kind of scary and we're here to make trouble or get you in trouble. And that's not the case. We're always happy to talk through any kind of ethical dilemma. And help where we can. And if we can't help, we might know about a resource that can help. But I think, knowing that you might not have the right answer and knowing that it's okay to ask for help are the two biggest things that I would like to remind professionals of.
That's good. Kathleen, do we have some questions that have come in that we need to answer before we end our time together?
We do. And I still have this advocating slide up. And one question that I want us to address before we go to the other questions has to do with what's reasonable timeframes for advocating. So for example, at the facility level, speaking to the person in charge or the executive director, is it reasonable to think that this step would take 1 or 2 days or 1 or 2 weeks? Again, contacting the ombudsman, once that phone call has been made, how long will it take, or what's a reasonable expectation for the ombudsman to reach out, schedule the appointment, and then actually come to the appointment? Again, is that same day, within 48 hours, within a month? If you file a formal report, again, what's a reasonable expectation? And then contacting lawmakers. Can someone speak to that just a little bit so that we have an idea of how long the process can take when you truly are advocating for someone?
Sure, I'll start, and then Mindy, certainly feel free to jump in. So in terms of like reaching out to the ombudsman program, we are to initiate a response to any concern within 2 business days. Now that may be making that initial phone call to connect with the individual and to gather information, unless it's a concern related to abuse and neglect, and then that's within 1 business day. And then from there, depending on the situation, we'll determine if we schedule a time to get out to the facility or what the next steps are going to be. And certainly we have to prioritize the different complaints that are coming into our program, because just in Dallas County alone, we handle about 400 complaints every month. And so prioritizing that, but yes, you should at least have an initial response from the ombudsman within 2 business days. With long-term care regulation, when you file that formal complaint with them, they are going to prioritize what their response time is. And certainly right now, what we're seeing during COVID is any concerns related to abuse and neglect or infection control. Those are the 2 areas that they are most focused on right now, and that are going to get the fastest response from them. And then at the facility level, I think it really depends on each individual situation and how urgent that concern is, how long you want to give them. You know, I don't know that it's realistic to expect within a day for them to have a response. Again, it's going to depend on what's going on. But if you haven't heard from them with at least an initial response within a couple of days, then maybe reaching out again or checking with somebody else there at the facility. And Mindy, if you want to jump in as well.
Yeah, I think one extremely important caveat in contacting the ombudsman is that we operate based on consent from the resident. And so, yes, we are going to return your call in the timeline that Susanna specified. However, whether or not we even can take action or how long that takes is really dependent on what the person at the facility, the resident, has to say about our actions.
Okay, thank you. Okay, so some of our questions from our participants include things like designated caregiver visits, who must be tested and have negative COVID results in order to visit their loved one, who's responsible for paying for this frequent testing if the community is requiring that?
Most insurance companies are covering testing at 100% right now. So I would really encourage individuals who need to be tested to contact their insurance company and see what their benefits are. For individuals who do not have coverage, there's a federal program that's paying for COVID testing. And so you really shouldn't have to be paying for it unless you're doing something like a a rapid test that gets, immediate results. I know some places are charging for those, but it kind of depends where you go. And in some cases, facilities are providing this testing free of charge, but not every facility is doing that.
Okay. The next question is around vaccination. What are the guidelines around vaccination? If you have proof of vaccination, do they still require testing, or is it okay for them to still require testing?
Yeah, that's a great question. Yes, right now, nothing has changed in terms of the guidance from the CDC and then also through CMS for individuals who are vaccinated. And I think that really stems from the fact that they still don't really know for people who are fully vaccinated whether or not they can still be asymptomatic carriers of the virus. And so for now, yes, facilities can still require, and they should require at least that initial test, and then depending on what their testing strategy is, but yes, they can require individuals to continue to be tested on a regular basis, even if they are fully vaccinated.
Okay. And how are facilities ensuring that all of their residents and caregivers get vaccinations?
It might be good to pair that with another question, which is kind of asking from a totally different perspective, which is it legal for a community to mandate that visitors or contractor healthcare workers have an experimental COVID shot before being allowed in the building. So the question is being asked from two totally different perspectives.
Sure. Yeah, that's a great question. And so, like you said, it is still an experimental vaccine, and because it got that emergency approval, they cannot require individuals to be vaccinated. And I just totally lost my train of thought. Sorry, but yeah, they cannot require it. What they are doing. So a lot of our providers partnered with pharmacies to have the pharmacy, either CVS or Walgreens, to come out and do vaccination clinics on site. Not every facility chose to participate in that, but in Dallas County, we still had a large number that did do that, and they did 3 separate clinics. And so, you know, we've seen pretty good success rate with our residents, especially who have chosen to be vaccinated. Not as high a percentage of staff who have chosen to be vaccinated. And so I know they are still working to educate staff on the importance of being vaccinated, but certainly there are other factors at play there. Just, you know, that's not unique to people working in long-term care, but we've got people in the community who don't trust the vaccine, and for understandable reasons. And so still working on those efforts to get more people vaccinated at this point.
So to take that a step further, if you have a resident in a community who is not wanting to get vaccinated, does the community have the right to require them to quarantine or to restrict their movement within the community? And what are you seeing as far as that goes?
So no, I mean, they should only be requiring quarantine in the event that somebody is new being admitted to the facility. They have to quarantine for 14 days, or if they're gone overnight, you know, for a visit outside of the community, then that would be appropriate to quarantine then. But in terms of a resident not being, choosing not to be vaccinated, that in and of itself is not a reason to quarantine that resident. It also should not be restricting their movement within the facility. They still have the right to participate in group activities, again, following those social distancing requirements and you know, wearing proper PPE and all of that, but they still have a right to do that regardless of their vaccination status. And, you know, the new guidance that came out from CMS again last week related to visitation, it addresses that as well, that it's opening up visitation for residents regardless of their vaccination status. So again, their guidance is that that should not prohibit somebody from being able to have these indoor visits.
Okay. And then you've talked several times about these new CMS guidelines that came out last week, and the Texas Department of Health and Human Services has not kind of gotten up to speed on that. So what's considered to be a reasonable time frame for that to happen, for them to make an update? Which one supersedes the other? Which one do the communities have to follow? And how are you all advocating for residents if the CMS one is more lax than the Texas Department of Health and Human Services?
Sure. So in terms of what's a reasonable time frame, I don't really know the answer to that. You know, we're certainly hopeful that it's going to happen sooner rather than later, but there, you know, there's some steps that have to take place for them to update emergency rules and everything. So I don't really know an answer in terms of what's realistic to expect related to that. And what was the other part of the question? I'm sorry.
So which one supersedes? So when they're different,
sure.
the communities have
yeah, so the facilities are required to follow the emergency rule that's issued by the Texas Health and Human Services Commission. At this point, that is what they should be following is in terms of their requirements.
Okay. And then
I also wanted to add quickly that assisted living facilities are not federally regulated, and so assisted living facilities are not required to operate within the guidelines of CMS. Most of the time, they choose to create regulations pretty close to what CMS has suggested, but for assisted living, it's just a suggestion.
okay, thank you. And then the CDC guidelines that just came out not that long ago talk about individuals who have both been vaccinated not needing to wear masks to be in close quarters together. And so my question along those lines has to do with, in a community, if the community still wants everyone to wear masks when they go out into the common areas, but yet people have been vaccinated, do they still have to comply with that, or what are the ethical kind of considerations about that and legal considerations?
Yeah, so those CDC guidelines that, like you said, recently came out and specifically said that they were for individuals not in healthcare settings. And so they actually do not apply to individuals living in long-term care facilities at this point. And so facilities should be requiring their residents and any visitors and staff to wear their face masks at all times.
And assisted living, is considered to be a healthcare facility?
For the purposes of that, yes, they are.
Okay. Next question we have is, are you aware of procedures for long-term care residents during the pandemic in the right to die states?
No, my expertise, and I want to say this is true for Susanna too, is specifically the state of Texas and more specifically Dallas County.
Okay. Are you aware of procedures for long-term care residents during the pandemic? Oh, I'm sorry, that's the same question. What education is being done to educate seniors and family members about the ombudsman program availability?
Yeah, so when we are out at facilities making our visits, we have large print business cards that have a description of our role and the service that we provide, and along with our contact information that we leave behind with residents. Facilities are also required to post information about the ombudsman program and how to contact us. They're also required to give information to residents and their families at the time of admission. And then certainly we do presentations out in the community where we're educating community members about our role. The senior source has information about us on our agency website as well as our Facebook page. And so any opportunity that we have to put information out there about our program, we're certainly trying to do that because we want people to know who we are and how we can be a resource.
Okay, great, thank you. Next question, or last question, is what is the current rate of vaccination among staff in long-term care in your counties and among residents?
That's a good question. I don't know. I don't have an official answer of what the rates are. As I mentioned earlier, we have seen a much higher number of residents who have chosen to be vaccinated. Staff, it really has varied from facility to facility. I got an email from one of the facilities that I visit that had 95% of their staff choose to be vaccinated. And that's great. That's really the highest percentage I've seen from our facilities in Dallas County. We've also heard of others where it's been 30 or 40% of the staff who've chosen to be vaccinated. So, I mean, there really is a wide range that we're seeing at this point.
Kathleen, I know we need to wrap up here. There's one question I've saved just to the very end. It's from someone who wrote to you ahead of time. And I tried to get a lot of the questions that were asked by email just answered within our conversation. I hope we got to a lot of them just through our conversation. But the last question is, Mindy, there's many folks who have no one to make that phone call for them to the ombudsman. They have no advocate. Any thoughts on either how we as professionals can be supportive of those individuals who have literally no advocate, or any outreach that the ombudsman program does for those individuals who might be lying in a bed and never be able to get to a phone to say, I need help. And maybe their voice even is not working very well. What are those people? What can you say to them?
Those are the people that we tend to be most concerned about. A lot of times we as ombudsmen are the only person who visits residents in long-term care facilities. So Susanna mentioned early on in our conversation today that we typically go door to door at facilities and speak to residents, and we try to speak to everybody in the building, maybe not on one visit, but over time. And so if there's somebody that we know has nobody, we may share that information with our team, especially in the event that that person moves, and we try to keep track of those folks. We also have the ability to seek things like whiteboards to communicate with people who may not be able to speak. There are ways. So those are the people. I mean, we're here for everybody in long-term care facilities, but those are the people that we're seeking out.
Thank you. Thank you, Mindy. Thank you, Susanna. Thank you, Kathleen. Thank you, Shannon. Thank you, Stacy. It's been a pleasure being with you today. And thank you for all of our participants who are part